with a physician helping you. Yeah, go ahead.
Since you're talking about kind of stopping some drugs, what about Cymbalta?
Okay.
Are there a lot of side effects of like going cold turkey off of it?
Cymbalta is a fairly new medicine that's equivalent, in my mind, it's fairly similar to Effexor, but probably the withdrawal is not quite as bad as the Effexor. But still, it's always better, really, even if it's Prozac and it's got a long. I mean, Prozacs last for weeks in your system. So when you stop that one, it kind of weans itself almost. I still would recommend if you're on 40 milligrams of Prozac that you cut it little by little before you stop it. Same thing with Cymbalta. I would do the same thing, so just to prevent it. I mean, why would, if you don't want to have dizziness and upset stomach and other stuff that feels terrible, why? I mean, really, unless you're having a terrible, most of these don't have terrible life-threatening type side effects. But if you had some rare thing like that, I suppose then you might want to stop it. But okay, I had another question in the back.
Yeah, if like you come off of Cymbalta and go on to something else, should you come off gradually? If you've been on like 60 milligrams of Cymbalta and go on something else, should you go gradual or?
Well, 60 milligrams. What's the lowest dose Cymbalta comes in? I think 60 may be close to that. Maybe the closest. I think it may be the lowest dose. If not, there may be only.
30.
Is there a 30? Okay, if there's because it's a capsule, right?
Right.
And Cymbalta. The question is again about Cymbalta is about how do you come off Cymbalta?
And go to something else.
And go to something else. Correct. Remember me talking a second ago about cross tapering medicines? So you might lower slowly down on one and gradually increase the other one. I always recommend that you do that if you can. And so you might, like what I would do is just kind of give you an example. Let's pick a medicine for me to help wean. Let's say Zoloft. Okay. So Zoloft, I mean, knowing how it comes in 25 milligram pills and 50 and 100. And so what I might do is I might cut your Cymbalta like from 60 down to 30. If it comes in at 30, you got to make sure it comes, whatever it comes in. I can't remember off the top of my head. If it comes in at 30, I might go to 30 and add the 25 of Zoloft. Do that for a week. And then I might maybe even come off of the Cymbalta and then try 50 of the Zoloft. So you see what I mean? You're kind of slowly coming off the one while you're slowly going up on the other. There's no absolutes in that. I mean, everybody's body's a little different. So some people that might be too fast. In other people, it's not fast enough. So you have to work with your doctor on that a little bit. So please, anything I say in here, don't take that as gospel and go back to your doctor and say, hey, Dr. Henley said this and this. And the guy's going to say, Doctor who? Who are you listening to? He's going to wonder who that quack is going around giving bad advice out. So, okay. So, any other questions about the medicine? I guess the side effects wise. Of course, I can't go through every single medicine and give you all the side effects of all of them. That would take us all night. But suffice it to say that the newer generation of medicines tend to have different side effects than the older ones. The older ones were more things like sedation. There could be some heart risk. They were a little more dangerous if you overdosed. You could die from the overdose of the old ones. And when I say old, I mean imipramine and nortriptyline and things like that. The newer ones, like the ones we've been talking about, Prozac, Zoloft, Cymbalta, if you overdose on those, they don't tend to kill you. So that's a good thing. So if you're worried about somebody who's suicidal, a physician is, that's why physicians are kind of more comfortable with the newer ones, is because they don't have to worry so much about that. But they still can have side effects, just that they're a little different. They may not be quite as sedating, so they don't make you sleepy as much. But although each one is a little different, so Remeron is kind of sedating. It's a newer one. But Wellbutrin is not at all. It's not sedating at all. Sexual side effects tend to be one of the most common side effects. And of all the common side effects that these newer generation of medicines have, it's really the only one that doesn't really go away with time. That one sort of sticks around. It's about 30 to 40% of people, depending on the studies and everything. And it sort of sticks around. I'd say I've seen some people after 6 months where it got a lot better and didn't bother them anymore. But for the most part, that's one that folks, that's the common one that folks complain about that doesn't go away. The rest of them, like nausea and headache and all that, they go away once your body gets used to the medicine, usually in a week or two. And they're not harmful in any way. Trying to think of anything else about the medicines. Anything sort of general that I can tell you. Does anybody have any questions about the medicines? Oh, have you heard anything about antidepressants and kids and suicide and all that? The controversy about whether antidepressants cause suicide, has anybody heard about that stuff? Actually, the FDA has a warning now in the label for all the antidepressants, the newer ones, for use in kids, warning about the risk of suicide. Now, here's the difficult part. I'll give you this is my own thoughts on this. It's certainly not me only. I mean, a lot of the other folks in the field think the same thing. My own thoughts on this is that back to the question about diagnosing depression in kids. We didn't talk so much about this, but you can see depression in different types of psychiatric illness. You can see depression in just depression, major depression, or major depressive disorder, which are just folks that get depressed, okay? That's it. Or you can see it in bipolar disorder, where folks get depressed, and then on the other hand, sometimes they get manic, kind of the opposite of depression, lots of energy, like they're on speed, but they're not on speed. They're just revved. Now, you have a child, and they're very young, so they haven't lived very long, and you haven't had a chance to really watch what their cycle of illness is, whether they've ever been manic or anything. Maybe they never have. Maybe the first thing you see is depression, and you think that's depression, regular depression, and you put them on an antidepressant. If they had a tendency, if they're really a bipolar child that has bipolar disorder, and you put an antidepressant on board, you might make their illness worse. So it's extremely difficult sometimes, and that even can happen in an adult as well. And yes, some subset of people, when you put an antidepressant, when you use an antidepressant with them, may end up killing themselves because they go into sort of a mixed manic and depressed state, which feels miserable and has a high risk of suicide. But anyway, the FDA, the studies that were done with these antidepressants, they try to look for that stuff, but as you can imagine, it's very hard. How do you know if they've never had a manic episode? So they used the antidepressants, and some of those kids committed suicide or had suicide acts. Most of the warning really is more about suicide attempts than it is about completed suicide. Thank goodness, because I mean the signal, the safety signal, looks like it's suicide attempts more than it is completed suicide. In any case, there's a warning in the label about that, and what you're supposed to do is you start the antidepressant for the depression in the child, and you watch and see, you watch them very closely. You see the physician very often. The family or the parents should really kind of watch the child closely to make sure they don't start to see the signs. What it looks like in the FDA warning, what it looks like is mania. It looks like where the child starts to get tons of energy, talks 90 miles an hour, irritable, agitated, that kind of stuff. Doesn't sleep. If that stuff starts to happen, then you got to really wonder if you got the right diagnosis, and you may need to get them off the antidepressant. So that's my own 2 cents about, do they cause suicide? I'd say if you don't use them in the right person for the right illness, they might. If you use it for the right thing, and part of it is you guys giving a good history to your doctors about what your symptoms are, and if you've been manic, for God's sake, please tell the doctor that. Most people who've been manic don't realize they've been manic unless they've seen somebody for it or something. And even then, still they don't sometimes agree that they've ever been manic. To them, it feels normal. It feels pretty good to be manic. And we're going to talk about bipolar disorder. I'm going to have a whole talk on that, a whole hour on that. So we'll talk more about it at that point. But any questions about it? I hope I did explain it fairly well enough. Make sense? Okay. The last thing I just real quick wanted to talk about was ECT. Have you heard of ECT? You ever seen One Flew Over the Cuckoo's Nest? ECT stands for electroconvulsive therapy. And I want to just say a word about that, because one of the things I know that Tom Cruise talks about all the time is how violent, how evil, and everything psychiatrists are. I guess he thinks that we have some agenda that we want to control the world. I don't know what it is. I don't have any agendas like that. One Flew Over the Cuckoo's Nest shows Jack Nicholson getting ECT. And in those days, when they did ECT, which is an electrical stimulation that they put through the brain, it causes a seizure, he was awake. I mean, the folks were awake back in those days. Now, it is an effective treatment, and it does treat depression, but they don't do it in folks who are awake.